So the next talk is by Professor Dr Rela. Everybody knows him. He's the CMD of the Rela Institute in Chennai and also the president-elect of the International Liver Transplantation Society. Mohammed, you tell us about liver transplant activity in the COVID-19 pandemic.
Thank you. I think I'm going to bring up with a lot of issues because continuing to do liver transplant is not as straightforward as one would think. We had a little survey of what people have been doing. This is really a general slide, and I don't know if you can see the arrow. I think if you look at this slide, obviously India is doing well. Good news is only 15,750 cases so far, 525 deaths, which is about 3%. I believe that I think it's difficult to hide deaths from COVID, but the only difficulty in death certificates in India is if somebody is not tested positive, perhaps they won't be able to put COVID in the death certificate. Whereas in the UK, in nursing homes and places where patients are not ventilated, if they have not tested, they would still be able to put it in the death certificate. So there may be a higher reporting rate in Western world compared to our population. The suggestion is there is no stage 3 disease spread yet, and I think I'll put a question mark over it. We need to wait and see. Obviously, the worries are, Dr. Sarkar would be able to say, I think when I looked at where we stand in terms of tested, COVID testing done, we are actually along with the third world, really. I think the countries below us are probably only the countries in Africa and South America. Most of the other countries have done much, much better than us. Now, in terms of really containing, we have difficulties. Now we have got the virus in Bombay, in the Dharavi area, where really there is 1 million population in 5 square kilometers. I mean, here the density, I said, is 450 per square kilometer, which is high, but there are very, very dense areas. And I'm really carefully watching what Maharashtra government is doing. If they can control the disease, I think we can all relax, really, because in terms of how Tamil Nadu government is doing, I can give you examples of how well they've done and how careful they are. Now, when we come to liver transplantation during COVID-19 pandemic, in the beginning, Dr. Soin said that it certainly affects the liver, which is a concern, at least for liver transplant surgeons. If we are going to be operating on the liver, dividing liver, taking one liver from a donor to a recipient, all of these are concerned if actually the viral particles are present in the liver. That was a news for me. I don't know if they have demonstrated that in postmortem findings. I think that Dr. Soin can answer a bit later. Now, can we actually apply the epidemiology that we see in the Western world to ours and then act according to that? I think that is also very difficult for me to really understand, because there is a huge difference in how Indian patients are responding and how the epidemic is spreading in our part of the world. There is a huge uncertainty about the understanding of the disease. I think our understanding is changing week by week, and how we screen patients are also changing week by week. I mean, we started a questionnaire about foreign travel, contact with patients. I think the travels have all stopped, and traveling between states have stopped, and the questionnaires have to be really modified. And I can tell you there are many asymptomatic patients. Now, our healthcare system is very well geared for really community medicine. I think this is one situation where we have a huge advantage compared to the Western countries. I really believe that, you know, in the medical schools, when they are still insisting on social and preventive medicine, I used to think, are we so outdated in our medical education? I think that is what is going to save us. I think there is a huge infrastructure for really preventative medicine. India has dealt with very well with smallpox, with polio, and I hope that that is what is going to save us at the end of the day, rather than improving our tertiary care. I think improving tertiary care is hardly going to prevent death in 1 or 2% of these cases. I think the focus has to be, and I think the Indian government is focusing on that, and lockdown is very much a part of that. And how rules are enforced is one of the problems. And this is going to be one of the answers for what Dr. Murugan asked. What is law, understanding of law, and how it is executed on the streets? We see on an everyday basis how the police officers behave with the public, and how people are really not treated really like human beings is something which is a worry. And that is really at the very bottom of how people are being treated. But there is also this worry. When a hospital identifies a patient with COVID and they are tested positive, there is a huge problem for individual hospitals. There are many hospitals which are designated as able to treat COVID-19 patients. We are one of those. All of the bigger hospitals, it's not a problem. For the government hospitals, it's not a problem. The smaller clinics, wherever they are testing them, if they are able to test them and if they are positive, if the doctors test positive, the local health enforcement people really go very heavily on them, because those zones are really designated as hotspots, and the amount of work that they have to do in those regions becomes very difficult. I'll tell you the practical difficulties of this when we are doing living donor liver transplantation. I'm not going to talk about immunosuppression, patient selection, and all of that. We'll go to the next one. Now, the first is about evidence whether it affects the liver. There are many reports now which have suggested that there is some derangement in the liver function test, but not a huge amount of liver failure associated with COVID-19. And in the largest study, if you see it, 1,099 patients, they have said that there is a slight derangement in the enzymes, AST and ALT, in the not so complicated patients, which are around 18%, and double the number in the complicated patients or the sick patients. That you would expect with any viral illness. If you do the liver function tests in any viral illness, that would be what you see. And therefore, the idea is there is no massive liver injury. Maybe the presence of the virus in the liver is a different thing, and Dr. Soin can explain at the end. Now, what has happened to organ donation and organ transplantation? If you look at the European registry and the UK registry, there is a rapid decline in the number of liver transplantation done, and the number of organ donation has been rapidly declining, and you can understand the reasons. But in order to understand, I worked in King's College Hospital until recently, and they have 1,100 beds, and 600 beds are occupied with COVID-19 patients at King's currently, and there are over 100 ventilated patients in King's currently. Now, the problem is these are not the patients in surveillance. In the UK, they will never admit a patient who's unwell. My cousin, one of my friends, they've all had COVID-19. They've had to stay at home within their house, quarantining themselves from the rest of the family. So how patients are being managed is very different. And the hospital patients are actually sick patients. And the mortality there, once they are in intensive care, is almost 20 to 30% for in-hospital intensive care mortality is extremely high. This is a point I was trying to make. And when you look at the United States, it's the same thing. If I want to read this to you, what people say and what is in practice is also very different. There is complete suspension of live donor kidney transplant, complete suspension of live donor liver transplant, but a significant reduction in the diseased donor liver transplant, both for liver and kidney. And significant reduction is this is really. If you look at the curve, this is up to the 11th of April. There is probably more than 50% transplants being performed in the United States, even at this situation. If you look at the predicted number to actually before the COVID epidemic, the numbers were actually much bigger than an average number in the previous year. So their numbers, if you look at the expected number to the real number, there is probably only about 40% drop in the numbers. So even now in the United States, they're very actively transplanting, and there may be some regional variations, but I don't think it's stopped that much. There has been a lot of recommendations from all of the professional bodies, ASTS and AASLD. I just go through what AASLD has proposed because it's very important. This is for disease donation, and we can also look at our own LTSI. Most of you know what our LTSI recommendations are. So liver transplant operation comes under, for the United States, what is called CMS Tier 3, 3B. So if you don't perform this or this, if this treatment is not available, it will harm the population, and therefore you cannot stop liver transplant programs in the American view. And they have given many recommendations, and the testing there, even there, is not available. See, one of the problems in the Western countries, in our countries, is we actually come up with proposals based on recommendations are based on really resource availability. People will say don't wear mask, and in my daughter actually works in the NHS as a junior doctor, and she won't be provided. She does ENT. She won't be provided with a mask if there is no high-risk patient. And now we have doubts about who is a high-risk patient, who's not a high-risk patient, and that is entirely resources dictating recommendations. The nurses will not allow people to wear a mask when they are actually wandering around. On the other hand, we have now got rules from some states in India where they say that you can't even walk down on the streets. The general public can't walk down without masks. So I think there has to be some regulations based on really what is science rather than what the recommendations based on really resource allocations or resources availability. I think that needs to be really very clearly stated around the world. At least for India, we need to have those statements made very clearly. Now, when we actually come to transplantation, we need to have some discussions about patient selection, and that patient selection can be variable both for DDLT and DLT. We need to think about the impact of surgery on the patient and donor. There was one publication from the United Kingdom on elective surgery inadvertently in patients who do not have COVID but turned out to be COVID positive post-op. It's almost 20% mortality. Just elective surgery, we are talking about simple surgery like cholecystectomy and really colonic resections. The mortality is 20%. Now we are wanting to do living donor liver transplantation, and if they are found to be COVID positive after a right hepatectomy, I would expect the mortality to be extremely high. Blood availability is going to be a huge problem in the COVID era. There is going to be no donations from external donors, and screening them before donation, I don't know how much of a possibility is going to be, whether we are going to do PCR before or whether we are going to do the antibody test before we can accept. And I think the blood banks are going to dry out in the next 2 to 3 months, and we will not be able to use blood for big operations which require major blood requirements. That is going to be a problem which we are going to face in the next few weeks or months. And we need to understand what the post-transplant outcomes are going to be and the immunosuppression. I don't think outcome has been a huge problem. Now, one of the problems has been really protecting healthcare workers and protecting institutions. I've said that to you, and I will give an example. Maybe I'll talk about protecting institutions a bit later in one of the slides. I think it is absolutely important that healthcare workers are protected, and where we are going to use these PPEs is going to be a problem. Do we use PPEs on patients, all patients? I'm not talking about, in fact, hospitals looking after COVID positive patients, it's the easiest, in fact, to have rules and regulations. The problem is going to be hospitals who are going to be looking after the so-called non-COVID patients or asymptomatic patients is going to be the biggest problem, because you can put all the resources in a COVID ward where all of these patients who are well are going to be lying down in beds or probably watching television and using their phones. There is nothing else to do, and everybody will be walking around with perfect PPEs. Whereas there are going to be patients who are walking around in non-PPE, non-COVID hospitals. That is, I think, a bigger problem, and how much of protective equipment you're going to use. And when a patient that you're actually looking after turns positive, after 4 or 5 days of looking after them, what are you going to do? And I'll come up with that example a minute later. Now we have come up with recommendations for this. Is our own LTSI recommendations we have sent as an initial response as a fear, which was exactly my view. Was a moratorium on all living donor or all transplantation, and then it was relaxed later on with a relaxation for acute liver failure and acute on chronic liver failure. Obviously, with shutting down for 3 weeks, these patients won't be able to wait. And now with shutting down for 5 to 6 weeks, I don't think any patient will be able to wait. The US view is the view that we are going to have. Now, donors, I forgot to mention that donors, cadaver donors having testing done is going to be a huge issue, because the sensitivity is only 70% for the RT-PCR, and that means 1/3 of our donors are going to have the risk of having COVID. So, is everybody, are the surgeons very happy to do? And in the background, I'd like to say one transplant surgeon in the US died of contracting COVID from a donor, positive donor. So how are we going to deal with it? Would we have time to actually repeat 2 tests? 2 tests done at an interval of 6 hours is going to be useful, or just 2 tests done randomly is going to reduce the risk? Because in the context of liver transplantation, doing 2 tests or 3 tests is not an issue, I think, in terms of resources, because those can be paid very easily for any number of tests for these donors. So that is something we need to discuss in disease donor allocations, really, whether we accept 1 test as negative and accept them. And it's the same for the donors. We, in the background, that when you do elective operations or for any condition where the mortality can be very high, is 1 test being negative for somebody who has a major liver operation adequate, or should we be doing 2 tests at intervals of 2 days or 3 days before we accept a donor? And similarly for the living recipients, whether one should be thinking of 2 or 3 tests is something that we need to be discussing. We initially did a survey of multiple centers, really, some involving United Kingdom and some involving US, and 2 centers where there was also disease donor transplantation, one from Maharashtra. I want to thank really Dr. Mathur and Dr. Ravi Mohanka for providing the data. And we looked at Tamil Nadu and Maharashtra. The green line on top is the disease donation estimates compared to last year. And the yellow line is the disease donation for Tamil Nadu. And you can see how things have been okay until the 15th of March. And after the 15th of March, the green is cadaver transplants. It's been 1 or 2 happening, but in Tamil Nadu for the last 1 month, we've had no disease donation at all. In terms of transplantation done per week, and this is really our center and Global Hospital Ravi Mohanka Center, and you can see the numbers have been okay until the 15th of March, but things have drastically come down. This is again, sorry, this is for Maharashtra number, and this is our center and Global Hospital Mumbai Center, where the numbers for living donor liver transplant, this is total deceased donor and living donor liver transplantation. We did a few at the end and the second week of March. So the numbers really for Ravi Mohanka has come down dramatically. And we took this survey for all of the centers. Now, there is a reason why I wanted this. As a baseline, I want you to look at our center. From the 15th of March, when really the fear came, and I think the lockdown came on the 18th of March, we stopped. This is not, ours is no disease donor in that, this is all living donor. And then I thought that around the 15th of March, it's going to be a disaster in the next 2 weeks. I didn't want to put the donors at risk when they are in the middle of a pandemic, when the hospital is going to be fully loaded with, because the government was having discussions with many private hospitals and asking us to take numbers and allocate beds for an intake around that time. So I didn't want our ICUs to be full of liver transplant patients or the donors in hospital. So we stopped. And nothing happened for 2 weeks. There were no patients coming through anywhere. So we started in the beginning of really April and did around, because these patients were been waiting around, and we did 5 cases. And last week we were to do 2 cases. We wanted to look at how the thinking of other centers were. But you can see that the other centers have been doing really more. I believe that they have been acute, but we didn't get the data, or subacute, or maybe they have done elective patients. So even in the beginning, in the end of March, people have continued to do transplants, and the beginning of April, if you look, there have been similar numbers, except for Medanta, they've given a combined number. And similar did Aster Kochi did a combined number, so they didn't split it up into the two. I wanted it to be split up into two in order to understand the way they were thinking. The way I thought was, it's going to be a serious affair. Let me just stop and see what happens in the 2 weeks. And nothing seemed to happen, and I started. Now, what happened to us last week, we had a child with acute Wilson's admitted, and the mother, who was completely well and totally asymptomatic, and this was an emergency, the child was sick, so all the tests were started. The mother had all the workup done, the CT scan done, went to every department, ultrasound department, met a psychologist, met a physician, an independent psychologist, a whole lot, because we have the system where a living donor is put through a huge amount of tests and people to meet. And the day before...
Excuse me, Mohammed, you're going to have to wind up. Yeah, it's about 20 minutes now.
Okay.
Yeah.
I'll wind up after talking about this, but I think it's important. The donor was positive. The donor became COVID positive, was completely asymptomatic. The child was negative. And therefore, we had to shut down everything. And we had about 30 people exposed to the donor. And the local authorities thought that we should shut down. And unfortunately, we were able to explain to them and not shut down the hospital, because we still had 50 patients in hospital. And there were many post-transplant patients also in the hospital. So this is what Murugan's question was, that if you start shutting down hospitals, and if you start putting people really under surveillance and they are going off work, how are we going to continue with this sort of work? I mean, this is the question and the recommendation we need really from the government. We're now going to talk about what finally, I'd like to use this as a final slide, is this pandemic is not going to go away. This is going to be sustained for the next 3 to 6 months. And the whole world is going to change, like Dr. Sarkar said. We're not going to be able to see patients in a very straightforward manner. Every patient who's walking into hospital, if he's an asymptomatic patient, you need to know what they are. And I think it may come in the airlines as well, that they may want to know whether they're immune or have tests done. And maybe people may have to carry what is like their immunization card when they are children. They may have to have a COVID passport where they may have to have tests done every week until they become positive. And if they have got antibody positive, maybe they can stop doing tests. And it's going to be really hospitals which are going to be where there may be a risk of transmission, and one may have to really alter the whole way we operate and we work the whole way. I think I'll stop to that and then and see if anybody's got any answers when they come up with patients who become positive. And the problem is, if you are managing COVID patients, it's not difficult. When they come with symptoms, you isolate them, and everybody's got a PPE. But when you've got a non-symptomatic patient with liver failure coming into your hospital, and everybody's been in touch with them for 4 or 5 days and then become positive, it's going to become a huge problem. I don't know if many people have had this experience, but this is going to happen to many of you. Thank you.